Hi, my name is Gaurav Gupta.
Thank you for inviting me to speak to you about how I approach the examination of patients presenting with neck pain and low back pain. I have nothing to disclose. I'm hoping by the end of it, we can take the various parts of the physical examination and be able to put them together in such a way that we can interpret the information as guide investigations and/or treatments such as injections. We will realize that there's some limitations to the physical examination that I'll present today. We will not be able to diagnose all central nervous system disorders, and there are some conditions such as malignancies, infections, visceral issues, or cardiac disease that will not be interpretable by the exam that we will review today, but are important to consider as part of your differential diagnosis for patients presenting with neck pain and low back pain. I'm also going to assume that you know how to do the tests that I'll be presenting today, and that once you've done the tests and we're able to consolidate the information, that you're able to guide the workup. I also want to point out that while this course is specifically looking at selecting patients for injections, that there's many ways to treat pain from these various regions that turn out to be mechanical and or neurologic in origin. So what I do in clinic when someone comes in with neck pain is look for an inflammatory disorder such as ankylosing spondylitis or DISH, which is usually highlighted by loss of range of motion. The next thing I do is look for upper motor neuron signs to see whether or not I can distinguish someone with a neurologic issue having a central nervous system disorder or a peripheral nervous system disorder. And then if it's in the peripheral nervous system, I try to get a sense of where in the peripheral nervous system it is. Is it more proximal at the nerve root or plexus level, or is it more distal, specifically in one nerve root distribution? One peripheral nerve distribution. Once I've done that, and I look to see if this is none of those things, then I try to figure out if I have a mechanical issue, is it coming from the neck and or low back versus another region that's close by, such as the shoulder or hip. And once I have all that information, then I'm able to try and get a sense of what else I want to do. Do I want to investigate further? Do I want to inject? And that's really guided by the specific situation. Uh, I want to point out that if you look at the textbooks, in general, the specificity and sensitivity for any one of the tests that we're going to be going through today is generally poor. And that's why I think it's important to try and put together as much information from the history, the physical examination, investigations to try and guide your approach. So the first thing that I do is look to see whether or not someone is able to move freely or not. If they're not, then I kind of get a sense of whether or not there could be a rheumatologic issue that needs to be worked up further. If they can, but I have to encourage them to move or I have to help guide the movement a little bit, meaning that there's more passive range of motion than active range of motion, start to make me consider whether or not there could potentially be pain limiting their movement or some other things such as centralization or malingering. So if we go back for a second, this is flexion, extension, rotation, and side bending. And these are relatively free and pain-free motions. This is demonstrating a patient that's not moving but is able to move forward if you push on the neck versus someone who has a fixed range of motion for forward flexion. Once I've done that, I want to get a sense of whether or not there are upper motor neuron findings. To try and distinguish whether or not it could be above the cervical spine, I use a jaw jerk, and that'll help guide whether or not I need to do other investigations, such as an MRI of the cervical spine and or potentially considering an MRI of the brain or vascular studies. So we'll go back for a sec. This is Lhermitte's, shock on the body, jaw jerk, hyperreflexia, hyperreflexia, a Hoffman's test, which is like a Babinski for the upper limb, hyperreflexia, hyperreflexia again, clonus, a Babinski response. Sometimes this part is challenging. Once you've ruled out a fixed loss of range of motion and a central nervous system disorder, if you believe that someone has a neurologic condition in the peripheral nervous system, how do you sort that out? I would suggest using two muscles from each nerve root. That way, you'll be able to distinguish whether or not someone has a peripheral mononeuropathy, meaning do they just have a problem with the radial nerve, versus are there other things involved at the C5 and C6 level that could potentially make this a plexus or a nerve root compression or compromise. So for C5, C6, I use deltoid, biceps, and/or extensor carpi radialis, all different nerve roots. For the C7 level, I'm using triceps as well as flexor carpi radialis. And then for the C8, T1 area, I'm using thumb abduction and first dorsal interosseous movement. For the sensory areas, C5 is just near the lateral epicondyles, T1 near the medial epicondyle, C6 near the thenar eminence, C7 near the distal tip of the third digit, and the lateral portion of the hand and finger, the medial portion of the hand and finger are C8. So once we have this information, then we try to get a sense of what that pattern looks like. And if it's concordant, then we potentially, if we have multiple muscles and a sensory loss and a reflex loss at, say, the C7 level, then we could potentially consider someone having radiculopathy or plexopathy depending on the particular clinical history. Versus if it's something a little bit more distal or in one specific peripheral nerve distribution with some positive compression tests, then we may be dealing with a peripheral neuropathy or peripheral motor neuropathy. So that's the deltoid, biceps, wrist extension, C5, C6. Those are the C7 tests. Thumb up in the air and first dorsal interosseous are the C8 tests. So this is the sensory evaluation, C5, C6, C7, C8, T1. Of course, this does not consider the peripheral nerve distributions of things like the median nerve and the ulnar nerve. But if you do find a sensory deficit, it'd be worthwhile trying to see how far this extends to see whether or not this fits in the specific distribution. And lastly, these are compression tests to look for compression of the ulnar nerve and the median nerve. So the last part is the palpatory examination. And really, I'm just getting a sense of whether or not, once I've ruled out other potential neurologic causes and rheumatologic causes, whether or not I can localize to a specific area that I could manage or inject. So I palpate over the TMJs, sinus areas, the scalp, over the greater occipital nerve area, over the lateral musculature around the neck where the facets are underlying, and then in the upper paracervical soft tissue, looking for trigger points. And that will help guide whether or not I need to do any further workup or whether or not I potentially can lead to management such as injections. So just to summarize, if I think that someone has mechanical neck pain, there's some injection options, trigger points, facet procedures, epidurals. If I think that someone has a nerve root compression, I can certainly consider an epidural or a nerve root block. If after doing my examination, I believe that this could potentially be in the plexus, and I can be a bit more specific about what's happening. If it's thoracic outlet syndrome and it's a mechanical cause versus a neurovascular cause, I can consider scalene injections. If someone has complex regional pain syndrome, then there's certainly some injections that can be considered of the brachial plexus or potentially a sympathetic block. And then finally, if I think this is a mononeuropathy, such as carpal tunnel or greater occipital neuralgia, then I could potentially inject those regions as well. And it'd be remiss not to mention that it is important to consider the shoulder exam as well, partly from an injection standpoint, but also to rule that out as a contributing cause or co-conspirator when it comes to people having these pain. Sometimes one particular area could be causing pain in the other. So a shoulder region issue could potentially causing secondary neck pain. A neck issue could potentially be causing secondary shoulder pain. It'd be important to understand this as well. But I know that you'll be getting a topic on approach to physical exam for the shoulder as well.